Now, our first speaker for the afternoon is Dr. Christel Hendrieckx, and Christel is a research fellow at the Australian Centre for Behavioural Research in Diabetes. She's a clinical psychologist who trained in Belgium and the UK. Her major interest is in people with type 1 diabetes and their perceptions of new treatments and technologies. Her key research project focus is on interventions to improve the quality of life of people living with diabetes and to prevent severe hypoglycemia. So I'd like you to please welcome Christel.
Thank you very much for the introduction, and especially also for inviting me to talk to you today about the topic, which is where I'm very passionate about, supporting people with diabetes with their emotional well-being. And just a couple of words about our center, because maybe not many people of you are aware of the work we are doing. So we are a national center based in Melbourne, and we are a partnership between Diabetes Victoria and Deakin University. And as the title said, which is quite complex, and I must say, I must congratulate the chair for pronouncing it so well. It's all about behavioral and psychological research in diabetes. Now, for those who would fall asleep, I start with my key messages. So this is actually the conclusion of my presentation. So even if you can't pay attention for the next 20 minutes, you will know what the summary will be. I'm going to talk today about diabetes distress. And what is diabetes distress? It's an emotional response to the burden of living with diabetes. And it's experienced by many people who live with the condition. It's very different from depression and needs another approach than when you live with depression. It's very easy to identify, and actually it's easy to reduce. And after hearing some of the presentations this morning, you could change the word diabetes in this concept by any other chronic condition, I believe. I said already what it is, so it's an emotional response to living with the daily challenges of a chronic condition. So when people feel distressed, there is a cause, and the cause is their diabetes. And being distressed goes together with a lot of negative emotions. People can feel worried, frustrated, concerned about their diabetes today, but also about their future. And we know from research that diabetes distress relates to the daily self-management that people have to do. There's the support they receive from their family and friends and colleagues. The healthcare system can cause some distress. Social aspects, for example, stigma, discrimination, and financial implications. So there is a context. Now, it's, as we heard this morning, having all these emotional responses to living with diabetes, it's very normal. It's actually, I would say it's abnormal if you wouldn't have these emotional responses. And we've conducted a national survey a couple of years ago, which is called Diabetes Miles. And actually last year we did a follow-up study, which is called Miles 2. And this surveyed more than 3,000 people in Australia, people living with type 1 or type 2 diabetes, asking about many different aspects of their diabetes management, but also their emotional well-being. And one of the measures we use, and I come back to that, was the PAID, which is the problem area in diabetes scale. And this is really a measure assessing specifically diabetes distress. And we say if people score 40 or above on a scale of 100, we call it severe diabetes distress. And these are the results of more than 3,000 people living with diabetes. A couple of messages you can take away from this slide is, first of all, that it's very common, as I said, and you see here, depending on the type and the treatment, it ranges between 20 to 25%, which means 4 to 5 people on 10 that you see in your clinic who live with diabetes are probably having severe diabetes-related distress. And the good news is that actually most of them were not experiencing high levels of distress, which is a positive message. So not everybody is struggling severely. What were the top 5 problems that they told us that they were struggling with most? And this is not only in the Australian sample, this is actually worldwide, worrying about the future and serious complications of their diabetes is the top concern people have, really all the chronic complications which many people experience after living for many years with diabetes. But also a lot of emotions, feelings of guilt and anxiety when their diabetes goes off track, or not knowing the feelings they have, whether these are related to their diabetes. Feelings constantly concerned about food and eating, and those, probably all people around here today do realize there is a lot about food in the diabetes management. So not very surprising that this comes up as a major concern. And then, of course, for those being treated with insulin, worrying about low blood glucose reactions. Now, it is very different from depression. And as I said, diabetes distress is related to diabetes. And we heard this morning already what the symptoms are or the criteria are to diagnose someone with depression. But actually, when you look at depression, it's about symptoms. There is no cause. There is not necessarily a cause or a context. So we diagnose is based on the presence of these symptoms, their severity, and how long they are ongoing. So, but this is without a context and a cause. And up till now, the studies have shown that probably double the number of people living with diabetes have depression compared to a general population without diabetes. But actually, this evidence has been challenged recently, and I also would like to challenge your thoughts about it with regard to what kind of support we need to provide to people living with diabetes. And actually, just this week, I found a paper which is still in press from colleagues from the US who have done amazing work in this area, Larry Fisher, Bill Polanski, and some of other colleagues. And they've used the PHQ-8, which is probably quite familiar to most of you, is the patient health questionnaire. This one is with 8 items, and it really follows the symptoms that we use to diagnose depression based on the DSM-5. And you can use different cutoffs, and that's what you see here. So they report the results according to a cutoff of 10 or more, 12 or more, 15 or more. This is according to the DSM-5 algorithm, and this is what we call the golden standard to diagnose diabetes depression, major depression. And their study was in type 1 diabetes. And you see, depending on the cutoff you use, it starts from around 11 people would have depression leaving, and when you put up the cutoff, it's decreasing to 4%. So this is actually, when you look at these numbers, you will say, yes, it's very common. But what they also did, they compared actually the score on this questionnaire with a clinical interview. And what they found is, based on the questionnaire, that actually we have high numbers of false positives, meaning with this questionnaire, we identify much more people that we would say they have depression than when you do a clinical interview. And when the message is out there that there are so many people with diabetes living with depression, I wonder, how have we established that diagnosis? How do we diagnose people with depression in our clinical practice? Do we really use a clinical interview, which is the standard, or are we just relying on what they tell us and we say, you probably have depression, maybe we should discuss medication? So I wonder how we are doing this. And so because of their findings, they have published quite a lot of papers challenging this knowledge about, are we actually looking at the wrong thing? Are we focusing too much on depression and not enough on diabetes-related distress? Because this is very relevant from a clinical perspective. These are two different conditions requiring different approaches. And my message today is not saying, look, people with diabetes don't have depression, because there are people out there who have to cope with depressive symptoms and depression, but really in our clinical practice to be aware of the difference between these two conditions and also the different ways we have to support these people. So their conclusion was in their study that most people with type 1 who had high levels of depressive symptoms were actually not depressed, and that these may be the measures we are using, the self-reported measures, maybe they assess diabetes distress and not depression. And actually, with the study they did, that the rates for depression were not very different from a general population. And as I said earlier, we often treat people for depression while actually they have diabetes distress. Now that we understand what is diabetes distress, what's the next step? We have defined a problem. What do we do next? Now, personally, my belief is, and I've been working in clinical practice for many years with people with diabetes, if you identify diabetes distress, this is best handled or best addressed by the clinical team who the person is seeing for their diabetes. Because diabetes distress is related to reduced self-care and with higher levels of hemoglobin A1C. And again, from the same group, when they looked at the correlations between a couple of self-care behaviors and hemoglobin A1C, in the first step, they saw that they were all significantly associated with depressive symptoms. But then when they added diabetes distress in their statistics, it showed that actually these self-management behaviors were more highly associated with distress and no longer with depression. So Larry Fisher came up with his conclusion, and he said, we must move beyond the tendency to place an artificial divide between emotional and physical aspects of diabetes management that can lead to labeling the emotional aspects of the condition as pathological. The two are so intertwined and interrelated that simply calling emotional side a comorbidity is counterproductive. A second reason why I think it should be addressed within the diabetes team is because people with diabetes want to talk to us about their emotions related to their condition. And we ask people in an audit in type 1 diabetes, has anyone in your team has ever asked how you feel about living with diabetes? And half said that they did. And then we asked, if it wasn't asked, would you like to talk to them? And you see again that close to half said, yes, I would like to talk to my health professional about how I'm feeling. A third reason is if we go back to the medical outcomes related to diabetes, and these are US data, but actually the results would be the same in an Australia study. And this is more than 1,000 people with diabetes, and this is the targets that is set up by professional organizations for hemoglobin A1C, which is below 7%. And you see that still around over the years, still 50% of our population is not reaching that goal. And if you look at combination of blood pressure and LDL cholesterol levels, you see hardly, not even 20% are reaching the target. So if we keep sticking only to our medical approach, it doesn't seem to get to the targets we need to achieve. So maybe including talking about the emotional aspects of living with a condition can improve outcomes. So I would like to say to you, look, diabetes distress is not at all difficult to identify. It's an easy job. And we talked a lot this morning about settings and structures not working with us, but actually there is so much you can do on an individual level, you with a person, you working with a person with diabetes. And you can do it in different ways. In your consultation, you can just ask the question, how diabetes impacts this person's life? Or you can make it part of the conversation. For example, if you talk with them about their blood glucose levels or some of the medical test results you discuss with them, you can just ask about, how do you feel about all this? How do you feel about your last hemoglobin A1C? How do you feel about your blood glucose level? And think for yourself, how often when you talk about examination results or lab results, you look together to the numbers and you say, this is what you should do to get these numbers down or to get these numbers up. How often do we ask our patients, how do you feel about these test results? How are you worried about them? What do you think you can do to make them better or make them more within target? So this is really an occasion for us to talk about the emotional aspects of living with diabetes. And some of us might feel more confident in using a questionnaire as a starter of the conversation. And there are good measures, good validated measures out there to measure diabetes distress. And if you are interested, I can give you more information afterwards. Now, whatever way you do it, it's up to you, I think. It's up to a couple of factors, depending on what your skills are, your confidence. The person with diabetes using a questionnaire is not the best way for all people. Some don't understand the questionnaires. It's not within the way in their culture you would ask these kind of things. So also take into account the preferences of the person with diabetes and your relationship. And you will know, oh, for this person, it's better just to have a conversation, but for another, it might be better to use a questionnaire. I just want to share an experiment which was done quite a long time ago, where they asked health professionals, ask one of these two questions at the start of your conversation, and then sit back and don't intervene at all and listen to what the person has to say. And they said 5 minutes, but I can tell you actually, if you ask these open questions, people are not going to talk for 5 minutes. We often think if we ask these questions, they will go on and on and on, and my whole consultation time will be used up by them. This is actually something we do not need to fear, because 2 minutes and they are done. You can have a conversation. And then they asked the health professionals to use the information they got from the person with diabetes, to use it for the rest of their consultation. And sometimes I wonder how we can work with people with diabetes who manage their diabetes most of the time. If you see how many hours a year do they spend with us and how many do they spend on their own. So if we talk about their targets, if we talk about changing lifestyle, changing insulin regimen, if we don't understand what's going on in people's life, how can we actually support them? I don't think you can, as Larry said, you can't make the distinction between these are your medical outcomes and this is your lifestyle or your personal life. This is really one thing to talk about. These are some examples of the questionnaire I was talking about, the problem areas in diabetes, some examples of the items. It has a score from 0 to 4, and you can calculate the total score, but from a clinical perspective, that's not necessary. Just look at the items that score very high and talk about these specific problems that the person is faced with. Diabetes distress is actually easy to reduce, and we were very fortunate last week that we had Jackie Sturge as a guest in our center. She's a nurse and a professor at King's College in London, has been working in diabetes for a long time. And she's actually said, what you probably need most during that conversation is a box with tissues. And I think she's right. And what we often underestimate as health professionals is that the first intervention is build a relationship with our patients, a relationship based on trust, respect, and empathy. And that's already the start. And there's not much you have to do about it. It's just going to happen depending on how you build up your relationship. The second intervention is just listening. And just, we heard this morning, acknowledging that these feelings are very normal is already reducing diabetes distress, actually. And how am I going with time? Still okay? 2 minutes? Yeah, okay. She set up a clinic which was called a diabetes listener. And what she did, people were referred to our clinic when they were considered as difficult, that they had difficulties in coping with their diabetes. And just, this is an abstract of her paper showing that when it's purely diabetes distress, already in the second appointment with that person, she saw an improvement in their diabetes management and how they were dealing with it. While the second example is a man who has not only diabetes distress, but also depression. And I think there is where we probably would need a referral to a mental health professional, when it's the combination of distress and, for example, depression. So there was not much change in the second appointment. I might skip this for reason of time. We are a little, when I listened this morning to Rosemary, their work is such an inspiration to us. We are actually a young center. We celebrated our 5th anniversary last year. So compared to their center, we are toddlers. Well, they are already young adults, so we can learn a lot from them. But we are finishing a resource for diabetes, for health professionals working with people with diabetes. And it will have a handbook talking about emotional well-being, but also questionnaires that you can use in your practice, in fact, and information leaflets for people with diabetes that you can hand out in your practice. So this is coming up soon, and it will follow with some training in the future. So to summarize, people with diabetes are constantly faced with challenges, both emotional and behavioral. And they want to talk to us about what it means for them to live with a condition and to receive support. And because that emotional aspect is impacting on all the other aspects of the diabetes management, I think it needs our attention. But also from our perspective, we heard this morning about a burden put on us, but actually, I think working with people with diabetes is very rewarding. And it's also when you work in that positive environment with a person with diabetes, I think you will get further along the way. It's a win-win situation, if you ask me. You feel you achieve much more when you understand what a person's challenges are, what's going on in their life. And you might think it will take more time, but in the end you will gain time, because the way you will work with that person will be more cost effective. And people with diabetes, we know when you work in that empowerment way, that they feel more empowered and that they are much more satisfied with their relationship with us. And yeah, it also protects us from a burnout, I think, if you can work in that more positive setting. Thank you.
Now, do we have any questions for Christel? Sorry, I'll just...
Hello, Christel. I'm Nicole Brown, a diabetes educator from Sydney. Thank you for that excellent presentation. My comment relates to the suggestion that we can raise the agenda of emotional issues when we're discussing test results with patients. There's been some previous research that indicates that a measure like a patient's hemoglobin, HbA1c, doesn't in any way relate to how they actually feel, symptomatically or emotionally. And I can see what you're saying, that could be an opportunity to open that discussion.
Yeah.
But I think there's other aspects of how someone's really coping, or other situational factors which better facilitate those conversations, in my experience.
Yeah, thank you for bringing it up, because this is something I'm really passionate about. These are hemoglobin A1c and blood glucose levels are numbers. And the way we talk with our patients about these numbers is often judgmental. You have not been a good boy. You have not been doing well. These are not exams. This is just the blood glucose level is the glucose in their blood. That's what it is. But it's not a judgment how well they are managing their diabetes. And talking in a positive way about blood glucose levels. Sorry, I really want to share you with this, my knowledge about this. If you look at their numbers, we are trained as medical health professionals to solve problems. Well, maybe we can do it differently. And when we look at blood glucose levels, first look at those blood glucose levels that are in targets. Because as one of the speakers this morning said about resilience, this is where the person feels they are skilled. Look at the days that are within target. What is the person doing that day? What is different that day with another day? And what are their skills and confidence that we can use to target the blood glucose levels that are above and below. But we are so well trained looking at what's going wrong. Let's have a look to what's going right and learn from them and work in a positive way around numbers.
My name's Eileen Collins. I'm a credentialed diabetes nurse educator from Melbourne. Thanks, Christel. I just have a comment also. I think we lose an awful lot of clients between childhood and adulthood. They get lost, and I think a lot of it's about the fact they feel judged. And we may not mean to judge them, but I think Christel's quite right. Our language and focusing on hemoglobin A1C. For the last few years, I've been involved in an adolescent program, Teams Empowered to Actively Manage Type 1. And one of the things we did in that was we were very careful about our language, talking to teenagers about their blood glucose levels being above target, not bad or good. And in that program, we did a couple of sessions with parents. And in the evaluation, parents, one of the things they said made one of the biggest differences to the adolescents was the change in the way that we talked about taking the judgment out of the blood glucose levels. Yeah. And I think that's really important. Yeah. And I'd just also like to say I totally agree about it's after 25 years when I used to think if people came and they were sad, it was because they were depressed. Now I say to people, how do you feel? And when they say awful, I say, well, no wonder. And it's a bit like Rosemary said this morning, not normalising their feelings, that yes, this is relentless. It doesn't go away. It's every day. So thanks, Christel.
You're welcome.
Hi, thanks, Christel. My name's Larissa Burrell. I'm a mental health nurse from a community mental health service in Melbourne. I wanted to just, wanted to just back up what you were saying about numbers and targets, and because I think that we also need to take on board that it's actually a failure with the interventions that we're providing.
Yeah.
If the interventions that we're giving or we're working on with people, they can't actually do, then the treatment doesn't work.
Yeah.
And they're never going to achieve those sorts of goals.
Yeah.
And they are just numbers. Yeah. And just to add on to the idea about judgment as well, I think that's where Diabetes Australia's put out a brilliant position statement about the use of language.
Yes.
And I guess from my own personal perspective as well, that, you know, using words like diabetic, schizophrenic, don't help people. They just put them into a box and they tell them they're different to everyone else. And they also say, oh, you're different to me.
Yeah. Yeah, thank you. Thank you. Coming back to that comment about the interventions, the possibilities we have to help people with diabetes, I agree with that. But on the other hand, think about what it means to manage your diabetes day by day. Calculate how many finger pricks these people have to do. And when you live 20, 25 years with diabetes, what this means. So there are a lot of tasks we ask of these people. And I think we ask too much. And if they don't reach the targets of 7% hemoglobin A1C, maybe it's just not doable for you can be a micromanager and get to that number, and you will have a good hemoglobin A1C, and your doctor will congratulate you. But the stress that goes together with maintaining that number can be really overwhelming. So when we see these numbers that more people are achieving an 8%, maybe that's what we can expect. That's doable. That's achievable. And maybe the 7%, look, maybe these people don't want to do all these extra efforts for years and years and years. Try to imagine for yourself what it means on a daily basis to do the finger pricks, inject insulin, all the other complications that are above your head.
I'd like